Now I'm going to go into the portal, and again, I want to remind you, we are not license driven, we're transactionally fee based. We make money if you're making more money. Now, because we're not license driven, you can have 1 or 1,000 users. It doesn't matter to us, and we recommend you have as many as you need. The portal is HIPAA compliant, and it's PCI DSS level 1 compliant, which means it's the most secure financial servers in the world. None of the financial information of your patients is ever stored on your local computers or servers, and none of your staff ever has access to the full financial information of any of your patients. This meets much of your red flag certification and compliance and may save you tens of thousands of dollars of redefining how you handle patient financial information. Now, once you log into the portal, it opens up to a tool we call the Daily Dashboard. Quite honestly, this is a management tool. It's simply something that is a snapshot of the financial activity from multiple looks going on within your system. It won't be your frontline people who are interested in it. It's more for your C-level and supervisory people. At the top of this taskbar, you see there are 4 tabs: eligibility, payments, reports, and administration. Your frontline people will use eligibility and payments, and your management and C-level people will use reports and administration. They're very robust reporting capabilities, putting information at your fingertips that you may have had to hunt for from multiple locations before. I'll touch on that briefly after I go through the portal itself. Now I'm going to go to eligibility, and I'm going to run an eligibility for you and take it all the way to collecting the money from this patient. Now, these patients are real patients. We've changed their names to stay HIPAA compliant with written permission from them and the practices that provided them. We're going to real payers and in real time. Your patient would function exactly the same you're seeing here because these are real patients and transactions we're performing. Now, since the patient demographic is built in, we've loaded it, excuse me, you can search by patients through multiple criteria. If you're a high volume group, you're going to want to search by the social, the medical record, or account number, so you go right to that patient. You don't want to put in the name Smith and have 500 names come up for you to search for. I'm going to go ahead and search under the name. Well, we'll go with 4 characters within a name, and I'm going to let the system find it for me. And it found a patient that matches my criteria. That's the one I want. I click continue, and please notice that it has populated the patient information for me. Now again, this is skeleton data. We don't give you the real address or personal information about this patient, and the only thing your staff is asked to enter into this screen are 2 pieces of information, both in drop-down boxes. The first is the place of service. These are your places or departments. And the second is the rendering physician. In the hospital environment, this would be departments. Now, it doesn't matter what your system needs. We'll customize it to your needs. Excuse me. I'm going to show you there are 3 levels of eligibility. You are not required to go through all 3, but there will be instances where you may want to. You know, some of how you use the portal depends on whether you pre-schedule appointments for procedures and you know what's going to be happening in that meeting or that encounter, so you can do the estimate then, or do they have to see the clinician first, or do you have frequency patients, or do you have patients you see very rarely? A lot of that's going to be based how we recommend the best practice for you. So if I go into the first level of eligibility, I'm going to show you what we call base eligibility. Now that was 5 seconds or less. You now know that this is an eligible policy for this patient. That's all you know. Now in base eligibility, you may need it. You may need it if you're scheduling appointments, but you don't know what the procedure is going to be, but you want to ensure when you schedule the appointment prior to them showing up, they have an eligible policy so you don't have surprises on the day of the encounter. If you have frequency patients you're going to see 24 or 36 times over the next 2 or 3 months, we would suggest the best practice to you is to run base eligibility once a week to make sure that policy hasn't lapsed. You don't want to find out post-adjudication that you have to collect 100% of the last 6, 8, or 10 procedures because they either met their limit or they didn't pay their COBRA payment or they let the policy lapse by not paying their premium. Protect yourself. The second level of eligibility is what we call eligibility plus. Now in this screen, if there were a remaining deductible, it would appear here. All of the co-insurance information and co-payment information appears here, but we give you more on this level. We give you the ability to look at limits of liability with the click of a button. And if you need the full 271, all you have to do is click the button. We'll bring back the full 271 for you. And you will note these documents can be 30 to 120 pages long. So we literally hyperlink based on your specialty or your needs, what areas that you'd be interested in. So you could go right to that area if you have any questions or issues. Now, about half our patients use this 271, our practices and hospitals use this 271. Half of them never use it. I will tell you, if for any reason you get an error message up here, click on the 271. It's going to tell you the reason for the error. Now, there can be multiple reasons why there's an error. They could have a plan where they belong to a union and they have to, excuse me, have a certain number of hours to qualify, and they didn't qualify. So it comes back as either ineligible or an error. It'll tell you. If your data that you give us has typos in it, one of the things you're going to find out as a instant insurance eligibility tool is if there's a policy number typo, a date of birth typo, or the gender that you selected for this patient was inputted improperly, it's going to tell you there's an error. Click on the 271. It'll tell you why. You can edit that patient in the portal in 30 seconds or less and fix it forever. But the data is going to identify if there's errors in it immediately. The third level of eligibility is the estimate itself. Now, you could have gone directly to this estimate. And I want to stress, folks, eligibility for us is a means to identify what the patient owes so you can get the money secured. If you have eligibility in place that you're comfortable with and you prefer it and it's as efficient as ours, that's fine with us. You don't have to go through these eligibilities. You go right to securing your money in pre-authorized and automated payments. But since we're in the estimate now, I can go ahead and search for my procedures by either CPT code, 1 through 5 digits, DRG if we've loaded it that way, HCPCS, or J codes, depending on what your qualifications and your requests are. Now, I put in 3 digits. It brings up all of the matching 992s for me. I'm going to go ahead and select several of these. Believe me, I know you would never select multiple 992s, but I'm going to do that for the sake of this demonstration. Each time I select one, it moves it over to the selected procedures. And I'll select one more. Also, you are not married to just one set of codes. You can go into another set and add those, which I'll go ahead and select a couple of these. You have the ability at this point to add modifiers to any one of the procedures if your people are trained to do so. Otherwise, we can create custom codes for your frequency patients or your bundled procedures, and then they just select that code and it prices accordingly. Next, we tell the system in-network or out-of-network. In this case, we'll say it's a out-of-network event, and since there's no deductible, we don't have to be concerned about that, and we get the estimate. Now, what you're going to see happen on this next screen is it's going to bring up the eligibility plus information, because if we went right to the estimate, you didn't see it to this point, where on the left-hand side of the screen, it shares with you everything you need to know. Over here, it is showing you the summary, total billable, allowed, what the insurance is going to pay, and what the patient is going to owe. And then you can actually view this online by procedure, where it shows you across and down the billed amount, the allowed amount, how the deductible, co-insurance, and copay apply. So we would train you and your staff to simply print this line item statement. It'll be customized with your information at the top. It shows what we just looked at on the screen, and we'll teach your folks to say, Ms. Linderman, the insurance is going to pay $595.98. You're going to owe $255 42. How do you want to handle that today? Ms. Linderman says, I can't afford this all at once. No problem. Can you afford $127.71? Yes. Can you pay the first one today? Yes. So we know what she's going to pay. But here's a key step. We asked her to sign this. She now agrees she owes this money. There's no longer an argument, and it eliminates the first reason why we have trouble getting paid. She now agrees she owes the money. We also add financial guarantor language into this, telling them there's third parties involved. If for any reason the third party doesn't pay what's anticipated, she agrees she owes the money, and furthermore gives us permission to charge the payment method selected. So we ask her to sign it. It's now time to schedule the payments. Now I have the ability here to collect it all at once or to schedule the payments, or if there's an odd number, let's say she agreed to pay $55.42 today and $50 a month, I could collect the $55 and then set up the $50 a month, but she's going to pay 2 payments, so I'll hit the schedule payment button, and you'll note it brings over the patient information. I'll go ahead and select the location of the service so the financials reconcile with the day of care and the location. She's going to pay $127.71. And she's going to make 2 payments. And she's agreed to pay it monthly, but here again is another best practice. If you have that frequency patient, you can collect your money weekly before you actually see the patient for those procedures. So let's say you're going to see him 3 times this week. You arrange the payment to be collected on Monday. Think of the advantages. You can tell your patient they don't have to check out at the end of the procedure. They can just leave. But from your perspective, you're prepaid. If they don't show up for a procedure, all you owe them is another appointment. You don't have to double book patients or triple book patients to ensure that you're not wasting time and have them sitting in the waiting room getting aggravated at you. But she's agreed to the month, so we're going to collect the first one today. And now remember, since the system is going to do this automatically, once I finish this process, I'm going to collect my money today. It's going to appear in my bank account. And then 30 days from today, it's going to collect the second $127.71 without the need to ever send a statement or an invoice, deal with a confusion call. The money will simply just appear. Now, we have multiple ways with which to collect the money. We can take a credit or debit card, and we can do that by swiping the card on the card readers that are attached to the computer or typing it in. We can take a check and either scan it if you have the scanners or need the scanners, or type in the routing and account number and turn it into an electronic funds transfer so you have your money within 24 hours, not having to wait for the check to clear for 3 to 5 days or as much as 2 weeks. Or we can have a payment method on file already captured for this patient. Now, in this case, what we suggest payment method on file, the real world is this. You're never going to get 100% of your patients to opt into pre-authorized and automated payments or a payment method on file. We know this, and believe me, every single client we've ever put onto this portal went in thinking they'd never get their patients to pay at point of care, and we have a 90% success rate collecting this money when we ask for it. And the fact is, the whole industry is moving to this model. Everything you read, everything you see. In fact, governments are requiring you to inform, state governments are requiring you to inform patients what they're going to owe at point of care pre-service. And remember, pre-adjudication is the only way you're going to get this money secured. Now, since I have a payment method on file for this particular patient, I'll go ahead and I'll use a payment method. Now, here's a best practice policy we always recommend. If the patient says, I don't want to do pre-authorized or automated payments, you tell them that's fine. We're willing to put you on cyclical billing. However, it is our policy we have to have a payment method on file so that if any balance ever goes over 90 days, we reserve the right to charge that payment method. Remember, our job is to protect you financially. Now, there's a 98.3% success rate at collecting this money on these scheduled payments. Yes, you will have the occasional credit card where they ran up the charges too much, or it expired, or it declines, or you'll have the occasional bank account where they come back NSF. 98.3% of the time that won't happen, and the system has some tools built in to alert you and capture another payment method if necessary. So all I do is click continue. You'll see it's asking me, is this what you want to do? Yes. I print the agreement for the patient to sign. It spells out specifically, again, customized with your information. It spells out specifically what we're going to do: process one payment a month, a total of 2 payments beginning today of $127.71. Please note the financial information is secured. This is the legal language giving us permission to not only collect today, but the subsequent payments without further notice. We ask her to sign it. We click next, and it's done. It has just collected $127.71, going to deposit it into my bank account, and it's going to automatically collect the second, payment. Now, I stated that to do this and explain it makes it seem cumbersome, so I'm going to run through another one from eligibility to collection of the money, just so you see how fast this happens when your people are prepared and proficient. So I'll search for another patient. Yes, that's the one I want. I will pick my place of service, my rendering physician. I'll go right to my estimate. And that was about 7 seconds. I now know it's an eligible policy. I'll go ahead and add my CPT codes. I'll select several of these. And just for grins and giggles, I have to add one more code. Select the benefits based on, well, I guess I missed. No. Obviously, she's an out-of-network for Dr. Chapman, but you notice here there's a remaining deductible, so I want that to apply. Ms. Crispin, the insurance company is going to pay $202.80. You're going to owe $852.20. How do you want to handle that today? Oh, I can't possibly pay that all at once. Can I pay payments? Well, yes. Can you afford $85.22, and can you pay the first one today? And if that's okay with your policies, then that's what we'll do. Yes, I'll print this, have her sign it, schedule the payment. Remember to tell what location she's being serviced at. $85.22, a total of 10 payments. And we want to start the first one today. And she has a payment method on file, so for ease of use, I'll just go ahead and use that. Print the agreement. Ask her to sign it. Click next, and I am done. I now have collected my $82, and then for the next 9 months, another $82 will automatically appear in my bank account without cyclical billing costs. Now, there's many other ways that you can use the payment screen. You can just collect money. You could use it by calling older patients and offer them the ability to pay in a comfortable monthly budgeted payment, have a empathetic healthcare script, which we can give you, that basically says we're healthcare providers. There must be a reason you're not paying us, and it will instantly spike your cash flow, because 50 or 60% of your existing AR patients will appreciate being able to put it into a normal budget. They're looking for a way to pay you, or they're afraid to tell you they can't. So there's several options available there. Just a couple of more quick things. The reporting, this is what we call the payment transaction report. I'm going to run this for today, and what you're about to see is every payment that's actually going to transact today on your behalf going into your bank. Now, you'll see the 2 we did, but many of these could be payments that were set up 2 months ago, 6 months ago, last week, for every week. These are the dollars that are actually going to transact and go into your bank account from whatever was scheduled for today's date. Now, what I want you to see here, which is very important, is the ability, if for any reason I have overcharged this patient, I simply click the refund icon. I tell the system I've made a mistake. I need to refund her $27.71. and it does it automatically with 2 mouse clicks, and I have just refunded her that $27.70. I could print her a receipt and mail it to her and avoid cutting a check, a cover letter, and all of the costs associated with the refund process. Also on this reporting capability, we will bring this report to you in an Excel spreadsheet with the click of a button, so that you now have the ability to manipulate and look at this data either by location, by department, by provider, and do forecasting and budgeting you probably haven't been able to do in one data silo before. We also will monitor who's doing the processing within the portal for you, so that you can either train them better, discipline them, or prevent fraud from anybody trying to do something they shouldn't. And this can be imported into your practice management or HIS system to upload and keep your accounting system fully up to date. Now, we have 3 ways we can communicate with your existing accounting program and practice management or HIS system. We can create a real-time interface, either HL7 inbound or outbound, or XML. We prefer XML. A lot of the programs out there aren't ready to provide it. We don't like HL7 as much because it's not as flexible, but we can do it. Now, if you're not a high volume group, we don't recommend it. All right, there's cost involved, not only on our end, but your vendor will charge you to set it up, and you may have to buy add-ons. Like, for instance, Meditech has to have iAtrix attached to it, things of that nature. But it's not necessary, because we're going to load 100% of your patients into the portal before you get started. The only patients that won't reside in there will be your new patients that come in, and it takes 30 seconds to a minute to add a new patient. But if your volume dictates it and you want the interface, it's there. Otherwise, we can use simple import, export, or if you had to take this report and sort it alphabetically at the end of the day and manually enter the payments into your accounting system, it's still faster than the way you're doing it today, because when a check comes in the mail, you have to open up the practice management system, search for the patient, enter the payment, and leave. And you do that 50 times during the course of a day. Whereas if you had the same 50 patients in a report in alphabetical order, you go into the program once, and in 20 minutes you could enter all of those patients. Okay, last couple of things on the portal itself. You have the ability to actually do cash flow budgeting based on the payments that are scheduled. I could go out for the next quarter, 6 months, and actually do a cash flow projection of what's anticipated at 98% confidence it's going to pay for either by department, by location, or as the company as a whole. And the estimates themselves stay in the portal in perpetuity, 7 years to stay HIPAA compliant. So I'm going to go ahead and search for some of the estimates we have just done. And in this case, I can open it, and I have the ability to look at it again. I would tell you some best practices based on having this available to you now, probably for the first time. I would give my super bill coders or my claim processors a username. I would have them look at the estimate we've given the patient and make sure it matches, so you don't have a typo of a code and avoid claim denial. When the insurance company adjudicates, you should have a user go in and look at this and make sure they paid you what they were supposed to. 1 out of every 5 claims paid by the payer is paid short. That's a national statistic. California just sued 5 major payers because they continued to do it for 2 years after being warned, and they're suing them for $150 or $200 million because they've been shorting providers for 2 more years. Also, since this is real-time information from the real payer for a real patient, if the claim gets denied, you should have a more palatable time appealing the claim. Okay. So that's the portal, and there are obviously more that the portal does, but our time restricts us being able to go into detail about the administrative uses and how easy it is to function. What I do want to touch on is the why. Why do this? I know you are being bombarded with things you are being told you have to do. Moving from ICD-9 to ICD-10, upgrading or adding an EMR, and of course being penalized if you don't by 2014. new audit procedures for Medicaid and Medicare. All of these are telling you with the promise someday they're going to, they're being mandated on you with the promise that someday they're going to make you more productive, more effective, more profitable. Okay, give them the benefit of the doubt, and maybe that's true. But there hasn't been a single EMR implementation that I know of that hasn't taken a year and cost twice as much or more than what was originally projected when you factor in the ongoing training, errors, and mistakes while you're learning. ICD-9, ICD-10, everybody is finally realizing they're going to have to run both for at least a year, because any claim you have in process on ICD-9, you still have to have the tools to finish it in case it gets denied. And the audit procedures, you're having to hire new people or train new staff to manage those. The one area that you can impact that can have immediate effect on your bottom line is the amount of money you're collecting from patients, what they owe, and when you're collecting it. And this is the type of impact we're talking about. This is a real client of ours, and we do this type of analyses with every prospective client, and then we monitor to make sure we're meeting our goals. This is a 10-doctor group. I've obviously changed or taken out their name, but they do about $12 million in gross revenue. It's a smaller practice. They see about 25 patients. Now that's gross revenue is payer and patient revenue. They see about 25 patients each. Before us, they were only able to verify about 50% of their patients' eligibility pre-service just because of the cost and sheer volume. They were doing it the way most are, either a telephone call to the payer or a visit to a website that the payer promotes. They want to do 100%. It was taking them about 15 minutes average to do eligibility at a cost of about $3.50 per eligibility. One person can do 4 at every 15 minutes in an hour, and they're paying that person $14 an hour. They bill patients roughly $300,000 in out-of-pocket billing monthly, and they were able to identify about 30% of it is going uncollected, either sitting in over 90-day or being sent to collection agencies. And that doesn't include the hard cost of cyclical billing. Remember, the national average for what we don't collect is 49%. So we took them for their word and assumed they were a little more efficient than the national average. They estimated it cost them about $9 when we did the analysis with them to send a statement, and they send about 3,000 statements out per month. The net impact we're having with this group is we are adding 1,085,152 additional net dollars per year to their bank account. Now, we're not going into someone's basement and printing this money. It's money they're due. They're either spending it now or they're not collecting it. So here's where those dollars come from. We're going to save them 62.5 hours a day on just the eligibility process. We average about 3,000 man-hours per practice on eligibility savings alone per doctor per year. And that doesn't include the hours of not having to send statements, not having to deal with confusion calls or begin collection activity. But on just this area alone, about 62.5 hours a day, saving them about $5,900 a month. If 3 out of 4 of their patients opt into the scheduled payments or a payment method on file, we'll reduce their billing costs by 65%, which saves them about $17,000 based on $9 a statement at 3,000 statements. And since they are not collecting about 90,000 of this 300,000 per their numbers, we will increase the amount of money collected by about $67,500. Again, if we are 75% effective. This is the real reason it's time to make this change. What could you do with another $1 million or $100,000 or $30 million? We had a presentation with a medium-sized hospital today, and the impact for them was going to be $36 million more net cash. Okay, that is the presentation. I'm right on time. I will see if anybody has any questions. You can either type them in or raise your hand. I do see that. James, can you hear me okay? James? James, are you there? Okay. James, there must be something wrong with your microphone because you're not able to speak to me. Victoria, I see you have your hand raised, but I'm not sure if there's a reason for that. So type something in if you want me to open you up. Victoria is one of my managers. I don't see anybody has any questions typed in. If anyone does have any questions, please, I'll be happy to answer them. Otherwise, by all means, I'm sure you'll be hearing from the consultant that invited you. Otherwise, please reach out to them. We want to sit with you to do the specific analysis with you, not only the financial impact, but to talk about what you do today, what your staffing abilities are, your patient mixes, so that we can identify for you best practices based on using the portal. I impress upon you again, the time to sit on the sidelines to wait to make a decision on how to resolve this is over. Every day that you use the post-adjudication billing system is putting you further and further in either financial challenges, difficulties. We had a group that told us last Friday they laid off 6 people. We hear about groups where doctors are taking second jobs in ED departments. You are seeing a rash of physicians selling their practices to hospitals again. The reason is it's hard to make money. And one of the reasons it's hard to make money is because the patient pay has grown to be too much. If 50% of 30% of your money is not paying and you run on 7 to 12% margins, this one issue alone is putting you in the red. And we can resolve this with you, and we look forward to working with each and every one of you as a client, and we will work very hard for and with you. Thank you all very much. Have a wonderful afternoon, and we look forward to working with all of you.